I would love to spend a lot of time talking about how wonderful the lectures have been so far, because they've been outstanding, and thanking everybody for inviting me to be here, but I'm going to try to save time here so we can get to our break on time, because we're running a bit late, but it's been worth it. So I'm Leanne Bricker. I work in Abu Dhabi, trained mainly in the UK prior to working in Abu Dhabi. I'm talking to you about genetic screening. Now, when I talk to my patients about what genetic tests I'm going to do and about genes and chromosomes, I talk to them about recipe books. And I talk to them about imagining that every chromosome is a recipe book. So your whole genome is a library of recipe books. And it's the recipe for life. And if there's something wrong with the recipe, something goes wrong. A bit like when Rachel made an English trifle in Friends, for those of you who watch Friends and didn't follow the recipe correctly. And there are three main types of genetic abnormalities. The commonest being aneuploidy, where there's an abnormal number of books. There might be a missing book or an extra book. And the one we know most commonly is trisomy 21, but for example, you can get 18, 13, monosomy X, triploidy, or other sex chromosome abnormalities. Then you can get copy number variants, and these are microdeletions or microduplications, and this is where you've got a missing bit of text in the recipe. So it could be a missing paragraph, a missing page, or even a missing few words. And the most classic example, and it's been mentioned several times today, is the George syndrome, but there are others. Or you can get single gene disorders, and this is when there is a spelling error in the text in the book. And when a mutation alters a protein that plays a critical role in the body, it can disrupt normal development and cause a genetic disorder. And there are some classic examples there. So if you've got 1,000 pregnancies and you want to be screening for genetic defects, what you need to know is that about 1 to 2 of those pregnancies will have Down syndrome or other aneuploidy. About 20 to 24 will have a major structural anomaly. And in that group with a major structural anomaly, some will have chromosomal genetic disorder, and about 10 will have genetic disease or a single gene disorder. Now, in the environment in which we practice here in the Middle East, we have a lot of consanguinity, as you know, and therefore we do have a lot of familial genetic disease. So part of your screening is taking a proper history and seeing where your patient has had premarital screening, for example. How do we test for these different types of abnormalities? It's been mentioned several times today, but you can either, for aneuploidy, you're going to do a rapid test and then a full carrier type, or what seems to be more common nowadays in the Middle East, and I don't know if it's happening in the rest of the world, is that the labs are offering this rapid next generation sequencing of all chromosomes. Or you can do a NIPT, but as you know, NIPT doesn't cover everything. But if you're looking for a copy number variation, a deletion or duplication, you have to do a microarray. And if you're looking for a single gene defect, then you're talking about either specific gene sequencing, if you know what you're looking for, so if you know the familial gene variant, or else you're going to be doing exome or genome sequencing, which is looking at all the genes. So historically, we've been screening for Down syndrome since the 70s. But it's only really in the 90s when first trimester screening came into place and it became more and more refined and the detection rates went up. Now we know that the combined test gives us a 90% detection rate with about a 5% false positive rate. And then in the 2010s, NIPT came on board, and NIPT is now pretty used quite extensively. So the two screening methods that you have for screening for fetal, mainly chromosomal abnormalities, but genetic abnormalities as well, if you combine with your ultrasound, is your combined first trimester screening or your cell-free DNA, your NIPT test. I'm not going to go into a lot of detail here because I know you all know what the combined first trimester screening test is. It's a test done between 11 to 13 plus 6 weeks, takes maternal age, the NT measurement, and the biochemistry of serum free beta-HCG and PAPP-A into account. And it has an up to 90% detection rate for a 5% false positive rate. And it has clinical add-on value because doing the PAPP-A does also identify women at high risk of placental dysfunction if the PAPP-A is low. And of course, if the NT is more than 3.5 or more than the 99th centile, then you need to consider that this could be something more significant going on that is not necessarily a chromosomal abnormality. And cell-free DNA, as we know, is analysis of fetal DNA in the maternal circulation that comes from the placental trophoblast. So it doesn't come from the fetus, it comes from the placental trophoblast. And sometimes that's why we can actually get false positives. It's very good for the detection of trisomy 21 with a very low false positive rate. It's also good for detection of 18 and 13 with a slightly higher false positive rate, but it's very important that you get a good fetal fraction in your sample. And there are many cases where you may get a low fetal fraction, and you may need to consider then what to do because you don't get a result, which I'll go into. The scope of testing is mainly for trisomy 21, 13, 18, and sex chromosome aneuploidies, and they are the expanded panels, which I will mention at a later stage. But, as has been said many times today, and I'm not going to go into this to try and save time, your 11 to 13 week scan is critical. You cannot just do NIPT. You have to actually examine the fetus by ultrasound as well. And I think that's been very, very remarkably demonstrated why today. And this is the data that everybody's been talking about when it first came out, Kypros Nikolaides' team's data, which showed us very clearly that if the NT is more than 3.5 millimeters, even if the chromosomes are normal, there's a significant risk of a major fetal abnormality. And the bigger the NT is, after 3.5 millimeters, the higher the risk and the less chance of having an alive and well baby. But look, even if it was more than 6.5, 15% had an alive and well baby, so you can never write the baby off, which I think is what Asma was saying earlier on today. So the clinical pearl I want people to take away with today, because I see a lot of bad practice in where I work, when patients come to me, they have an NT scan, the NT is more than 3.5, and the next thing the doctor does is a NIPT and delays their referral for a proper invasive test. And the NIPT is not the right test to do in these circumstances, because you cannot with NIPT detect copy number variants or single gene disorders. And just to explain to you very clearly that the additional value of microarray is very important. This is where you're looking for your copy number variants, because if the NT is more than 3.5 and the fetus has a normal carrier type, there's a 4 to 5% pickup of significant, clinically significant copy number variants. And if there's an additional fetal abnormality and a normal carrier type, it can detect up to 7% of cases. And if it's the heart or craniofacial malformations, it can go up to 10 to 15%. But you must also note that when you're checking for copy number variants, you can get variants of uncertain significance, and it's very important to involve clinical genetics in these circumstances. The first thing you would do is check to see if both parents have the copy number variant, because sometimes it's a non-pathological copy number variant. So if the parent has it and is unaffected, it's unlikely that it's a significant finding. So which first trimester screening test should you do? Well, obviously NIPT is a very good test, and it's very excellent at detection, and it has a very low false positive rate. But it is expensive, and it depends on the resources of your individual patient or the healthcare system you're working in. There are also higher failure rates of NIPT, and you don't get the additional information you would get from the serum screening if you did the combined first trimester screening. So what are the recommended strategies? Well, in different parts of the world, people do different things. In the UK, for example, I know they do the contingent model. Has that changed recently? I don't know, but as far as I'm aware, that they offer combined first trimester screening as the universal test, and they only offer NIPT to the intermediate risk group. In other scenarios, you might offer combined first trimester screening to your low-risk pregnancies, and then you would offer NIPT for the high-risk group. So if there was previous aneuploidy or women over the age of 35, or an abnormal NT scan, positive combined first trimester screening or if there was a known translocation. Alternatively, you could offer NIPT as a first-line primary screening test, but ultrasound is very important. You cannot just do NIPT, you have to do ultrasound as well. So just going through some things, understanding NIPT false positives. This could be due to confined placental mosaicism. It's the most common biological cause of a false positive test, because remember, the result represents the placental trophoblast, not the actual fetus. It can be from vanishing twin syndrome. Many pregnancies start off as twins. One fetus gets resorbed, and the DNA that you're testing is coming from the resorbed fetus, because it may persist in the maternal circulation. And you sometimes get these results that are very difficult to interpret, like there can be maternal mosaicism. We had a case recently of a positive NIPT for monosomy X. Did an amnio, the lab couldn't give us a result. Did another amnio, said maternal sample, and it turns out that the mother was a low-level monosomy X mosaic, but the fetus was in fact normal. And there's this maternal malignancy problem. If the mother has an undiagnosed malignancy or has recently been treated for malignancy, you can get DNA from the tumor that actually is misidentified as fetal DNA. And I won't go into detail what you should do if you get that kind of result, but because I don't think anyone is 100% sure at the moment what to do with those results. You can also get failed NIPT, and often people keep repeating it. Well, there's no point in keeping on repeating it if it comes back as a biological potential maternal malignancy, but if it's because of low fetal fraction, if you repeat it, you will get a result in 50 to 60% of cases. You might get, your second test might still come back being unable to report for you. And we know that actually that's possible, that the placenta is smaller in some trisomies, so it's perhaps why the fetal fraction is low. So there's a slightly higher rate of aneuploidy if you get a no-call result in a NIPT. So I think you have to take the individual circumstances into account. Why are you doing it? If it's on a 25-year-old and it's your primary screening test, you might not offer an invasive test, you might offer a detailed scan instead. But if it's a 42-year-old, spontaneous pregnancy, there's a high risk it could be aneuploidy, and you might therefore offer an invasive test. What's very important with any of this testing is that you actually counsel your patients properly before and after. How many times have we seen patients who've been told their NIPT is normal, they come along for their 20-week scan, there's significant abnormalities, and they're very upset because they were told their baby's normal. They need to understand that this is a screening test, it's not a diagnostic test, none of these tests are, and that it's not a definitive yes or no. Screening is obviously optional, and it doesn't screen for all structural abnormalities, single gene disorders, etc. And so therefore, you still have to do all your other routine care and your routine investigations for the mother. And you must make it very clear to them what the expectations is of the result of your testing. What do you do if you get a low-risk result? You carry on with normal care, but you still offer your mid-trimester ultrasound scan. If you get a high-risk result, you should never make a clinical decision on a positive result or of definitive management. You must then go on to doing an invasive diagnostic test to confirm the result. Certainly in Abu Dhabi, we would never do a termination of pregnancy for a positive NIPT test for trisomy 18 until we've actually confirmed it with further testing. There are some special circumstances a lot of people ask about. The first one being, what is the value of the expanded NIPT? Well, I'll just explain to you that most experts in societies advise against offering it as a routine test. I feel very strongly about this. We get many patients coming back with a positive expanded NIPT, causes a lot of anxiety, there's a very high rate of false positives, it has a very low positive predictive value, and I would argue that it's not a very helpful test in screening. And nobody is currently recommending it, apart from the companies that are selling the test. I would welcome the comments of other faculty on this. Also, we get a lot of patients coming and saying they avoided having a CVS because CVS is far more dangerous than amniocentesis. So they delay invasive diagnosis because they think they're actually protecting their baby by waiting for an amniocentesis. And this is information they've been given by their doctors. So it's very important for people to realize that in the right expert hands, CVS is as safe as amniocentesis in terms of procedure-related risk. And the difference is that because you do a CVS earlier, the background risk of miscarriage is earlier, and that's why it is perceived that the risk of CVS is higher than that of amniocentesis. So don't delay invasive diagnosis when it's necessary. And finally, people ask, should we be doing screening in women who've had IVF with PGTA? And this is a very important question, and the answer is basically yes. Because PGTA is effectively a screening test. It can give you false negative results that an embryo is normal. And it's actually, if you read the consent forms that the women sign when they're having PGTA with their IVF, there is small print that explains this, but women don't seem to know this, so you need to tell them. We still need to screen your fetus. The biopsy comes from the trovectoderm, which is similar to the placenta, which is similar to why you might miss something. With NIPT, same reason you might miss something with PGTA. The embryo may be mosaic, and so you should always offer all screening to women with, who've had PGTA, treat the pregnancy as if it's a normal pregnancy. So I'm just going to go through some case examples, just highlighting some important points. So the first case is a 32-year-old who had a positive NIPT for trisomy 18. It's her 4th pregnancy. Her first trimester detailed scan is normal. I say detailed scan because I'm talking about the kind of detailed scan we've been talking about today. I'm not talking about your standard first trimester NT scan and checking a few things. I'm talking about doing the ISUOG level detailed first trimester scan. And there's normal DV Doppler and no TR. Would you agree to termination on the basis of this information, or would you advise further testing? So you would advise further testing. What testing would you advise? Would you repeat the NIPT? Would you do a CVS? Would you do an amniocentesis? Who would do a CVS? Put up your hands. Who would do an amniocentesis? Because you're delaying the diagnosis, right? You should actually do an amniocentesis in this case, because this could be confined placental mosaicism. Specifically for positive NIPT, trisomy 13 or 18, with a normal fetus on ultrasound scan, could be a false positive. Because when you test the placenta with the CVS, you're testing the same thing as the NIPT tested. What you want to be doing is testing fetal cells, so you need to delay your testing till 15 weeks and do an amniocentesis. This actually turned out to be a normal baby with a normal karyotype, this case. Second case is a 34-year-old with an NT of 3.8 millimeters, otherwise normal scan. Would you offer a NIPT? The answer is no, you wouldn't, because if the NT is more than 3.5 millimeters, you should be doing an invasive test. You should be checking for chromosomal abnormality and copy number variants, and you might even go on to do exome sequencing at a later stage if those two results are abnormal. And in case 3, we've got a 42-year-old with 2 previous term normal outcomes with an NT of 2.7, normal scan. Would you offer NIPT? Or would you do invasive testing? I actually think in this case you would offer NIPT, because the NT is 2.7, it's just more than the 95th centile. But some patients, I think you have to offer the patient both options in this case. Offer invasive testing, but I think in this situation with a normal scan, NIPT is a reasonable option. And the last case is a 28-year-old. This actually happened to me. Gravida 3, 1 previous term normal outcome. She comes for her first trimester scan at 13 weeks, and the fetus appears female. I know that it's not 100% this gestation, but I felt in my hands I was certain this was a female fetus. But she tells me that she's already had her gender reveal party because she had a NIPT at 10 weeks. Gender reveal party is the biggest reason why women have NIPT in Abu Dhabi, not because they want to know if their babies have trisomy 18 or 13 or 21. Anyway, the baby was a male, she's already had a party, she's really, really upset. What next? Well, here we're either dealing with a case where I'm getting the gender wrong, or this could be quite a significant and complex disorder of sexual development, or it could be a vanishing twin scenario. So I explain this to the lady. I say, look, this is the situation. These are the 3 possibilities. She says, oh, I forgot to tell you. It started off as twins. She didn't mention it in any of her routine booking visits or in any of her consultations. But when I mentioned to her it could be vanishing twin, she actually told me that it did, in fact, start off as a twin pregnancy. That baby landed up just being a normal girl. She had to have another gender reveal party. But if there's no known history of vanishing twin, you have to confirm whether there is indeed a phenotypic and genotypic discrepancy, and you have to involve clinical genetics if the results are discordant, because that becomes very complex. So in summary, I hope I've kept it short so we can get back on track. In summary, you should offer screening to all patients, genetic screening to all patients, but ultrasound remains mandatory, even if you're just offering NIPT as your first-line test. You need to be clear about what these tests are, and that normal NIPT or combined first trimester screening does not guarantee a normal baby. You have to also remember that combined first trimester screening needs to be interpreted in the context of the whole pregnancy and the risk. It's not just about the fetus, it's also about the placenta. You have to confirm positives, never act on a screening test alone. Choose the right invasive test. Sometimes CVS is not the right invasive test, particularly if the baby is normal on scan. Obviously, if there's an abnormality, that's different, or if there are abnormalities, that is different. And remember, if there's an NT of more than 3.5 millimeters, don't do a NIPT, go straight for invasive diagnostic testing. Thank you.